Welcome very much to this webinar on drug susceptibility testing and treatment of non-tuberculous mycobacteria. It's part of the European Society of Mycobacteriology's webinars, and we are extremely happy that we have been able to plan and conduct this webinar. And thank you also to the sponsor, Becton Dickinson, who have sponsored this event. They have not had any influence on the program, but have kindly sponsored the event. Just a few practical notes before we start the presentation. During the webinar, you can actually send questions using the live chat window. So you need to sign into YouTube in order to use the live chat. Please also remember that the message you send, they are not private. Everybody who participate in this webinar, they can actually see the message. Also, please, if you have a question, that's very nice to get an interactive session, then just add your affiliation to your question. Afterwards, I will ask the speaker, Jakko van Ingen, that I'm going to present in a moment. I will give your questions, pass them on to you. So thank you again to Becton Dickinson, and please give me the next slide, Jakko. I'm very happy to present Jakko van Ingen. Jakko is a medical doctor. He has a PhD. He's a clinical microbiologist, and he's also head of mycobacteriology at Radboudumc University Medical Center in Nijmegen. Also, Jakko is president of the non-tuberculous mycobacteria network and has participated in many studies, especially on non-tuberculous mycobacteria, and published more than 170 articles and more than 10 book chapters. So it's a great honor, Jakko, to pass the microphone on to you. We look forward to hear what you have to say about drug susceptibility testing and treatment of non-tuberculous mycobacteria. We hear that the number of mycobacteria are increasing all the time. We know people grow elder, they get a biological treatment, they live long time with a chronic lung disease. So this is actually a kind of problem that we need to address even more in the future. And we do have some problems with susceptibility testing, but I'm sure you will touch that area much more now. Welcome, Jakko. Thanks for participating.
Thank you very much, Troels. It's always a pleasure to participate in any activity of the European Society of Mycobacteriology. It's a brilliant organization with very good but also very nice people, and the annual meetings are always a joy in terms of the science and the social context. So it's lovely to do something back for the society that has given me a lot as well. And I would also like to thank BD for supporting these webinar series, which I to date have really greatly enjoyed. So today's topic is on drug susceptibility testing and treatment of non-tuberculous mycobacteria. Now, and you can imagine that in itself is quite a challenge. So the drug susceptibility testing is not as well studied as it is in tuberculosis, or in fact in any other major infectious disease. And treatment is also still in its infancy. And we're looking at a grouping of, well, close to 200 mycobacteria. So you'll have to excuse me for perhaps not covering either your favorite bug or your favorite drug today. So feel free to use the comments to submit your questions, and we plan on having a long and lively discussion after the short presentation, because this is a topic that usually elicits more discussion than it is based on any form of evidence. So apart from thanking BD for sponsoring this, I think it's important to realize that for the work I do on NTM, some projects are in fact sponsored by pharmaceutical companies. I've listed them here. Most relevant is the fact that I've worked on the trials for the liposomal amikacin inhalation by IDSA, which we will discuss in the treatment part. So if I say anything there, you do have to remind that I was part of the design and the execution of those trials. Okay, management of non-tuberculous mycobacterial disease is just tough. I, in fact, spent all this morning discussing the patients that are currently admitted in our wards, and our wards are really inside the building that you see on the picture here, which is a classic TB sanatorium called Dekkerswald, and that's where we treat our patients with a multidisciplinary team. And that is something that, if you take away anything from today's presentation and discussion, it should be that this is the way to go. If you want to manage patients with NTM pulmonary disease or any NTM disease, and in fact with complex forms of TB, a multidisciplinary team is really, really what you need. You need pulmonologists, you need infectious disease specialists also for their knowledge of immunology. You need pharmacists to tackle the many, many complex drug-drug interactions and therapeutic drug monitoring considerations. Radiologists, of course, to monitor the disease extent and progress, and clinical microbiologists also to make sense out of drug susceptibility test results. And of course, routine diagnostic workup, so cultures and others. Now, apart from having this multidisciplinary team for managing patient care, we are also a trial site in multiple clinical trials in the NTM field, and we run a research lab focused on pharmacodynamics of antimicrobial drugs and learning from that to improve the use of drug susceptibility testing. Okay, we start with the disease and where we are in 2020. Now, obviously, the 2020 situation is not NTM, but is COVID. I realize that. But I do think there's a couple of things that we need to state about NTM. Pulmonary disease in particular, where are we at the moment? Well, we realize there's really two diseases. A fibro-cavitary disease, much like pulmonary tuberculosis, be it slower in its progression and affecting a distinct patient category, those with underlying pulmonary disease like COPD. And there is the nodular bronchiectatic disease, of which a representative CT slide is shown at the bottom. Again, a disease that affects a very particular patient population, elderly patients, predominantly women, no clear history of pulmonary diseases, and sometimes a history of bronchiectasis or recurrent infections, pulmonary or otherwise. And then whenever you hear people speak on NTM, what you'll hear is that the prevalence of NTM disease is increasing. Now, there's not a lot of very good research to support that. Although, as a clinician, it's obvious that more and more patients come to the attention of physicians with this disease. Whether the prevalence is really increasing, I would say yes. But if you look at the science, it's a mixed bag. In some countries, it seems obvious, and in some, it's not that obvious. But it's definitely a big clinical concern. And why is that? Well, because it's a very severe disease, but also because there are treatment regimens, but they have a very, very poor evidence base. They are hardly ever based on clinical trials. They're mostly based on cohorts and clinical experience, and the outcomes are pretty dismal. If you look at cohorts of Mycobacterium avium complex pulmonary disease, a good outcome, so culture conversion and then culture negativity until the end of treatment, is achieved in some 50 to 70% of the patients, depending again on that manifestation. Fibro-cavitary does worse, nodular bronchiectatic does relatively better. For Mycobacterium abscessus, it's just utter drama. And regardless of the disease manifestation, outcomes are very, very poor, with cure rates in range of 40 to 50%. And for both, what is really important to realize is that cure isn't everything, because the recurrence rates are also in the range of 30 to 40%, very, very different from TB, for example, where appropriate treatment, if it leads to culture negativity, shows then later on a very low recurrence rate, unless you live in high burden settings. So before going into drug susceptibility testing, and I tell you, that's going to be a tough ride with a lot of data and a lot of opinion and a lot of we really don't know. I think it's good to briefly touch upon the updated treatment recommendations, because new guidelines just came out a short while ago, and they are not too different from previous guidelines, but there are some notable differences. So treatment of Mycobacterium avium complex, the predominant causative agent of NTM pulmonary disease, which is the predominant disease that you see with NTM, making up some 90% of all cases. Extrapulmonary disease is only about 10% of the caseload, at least in our setting. So treatment of Mycobacterium avium complex pulmonary disease is done using a 3-drug combination as the basis: Rifampicin-Ethambutol and Azithromycin. And for those with very severe disease, intravenous amikacin is added to the regimen for the first 2 to 3 months. Now, Mycobacterium kansasii, the old boy in there, that's what I always call it. I mean, it somehow seemed to be more prevalent in the past than it is today, is treated a little bit like TB without pyrazinamide. It's rifampicin, ethambutol, and isoniazid, although the azithromycin-based regimen with rifampicin and ethambutol can also be used. And then Mycobacterium abscessus is just very complex. And essentially, the new guidelines say, in the initial phase, try and treat with 3 drugs that show in vitro activity. And that suggests that there are many more. The truth is, there aren't many more than those 3. So that's important to know. So a lot of macrolides, a little bit of anti-TB drugs, and then abscesses, it's just a whole different ballgame. So drug susceptibility testing. It's always been a tough field. Drug susceptibility testing of NTM. There's a lot of opinion. There's people who have hated it for decades. There's people like me who love it and who think it could be very useful once we've learned more about it. But the overwhelming majority of people working with it, I think, still share the opinion that we are not always sure what it means for some drugs. For some we do, but for some we don't, at least not yet. So as a microbiologist, I always like, to take you all back to the basics. What are the basic criteria for doing drug susceptibility testing? Why do we do it? Well, we do it because there's a patient who has a disease, an infectious disease that needs antimicrobial therapy. So if there's no need for therapy, why do testing? Also, you test only when the effective antimicrobial drugs are actually available to the patient. Testing for the brand new drug that's not available in your setting it's a nice academic exercise perhaps, but not clinically relevant. But the most important part in NTM is at the bottom. So parts 3 and 4. You can only do good quality drug susceptibility testing if the activity of the drugs in vitro in the lab is somehow related to their effect in vivo, so treatment outcome. Now that's always difficult in mycobacterial disease with multi-drug treatments, but that is a basic criterion. And it's not completely settled in NTM for some drugs. So the discrepancies may exist, but, and we'll get to that, there is a very big but. For a couple of drugs, these correlations are very, very clear, and hence it's useful to test for them. The other thing, also quite interesting, is that of course there's no need to do the test if you already know the result. So if there is no variation in susceptibility to a particular agent, why test for it? So if no resistance can emerge, if only that was true somehow, there's very little need to test. So the latter two, so correlation in vitro, in vivo, and variation in vitro susceptibility are the core topics that I would like to touch upon today before diving into treatment. Because the myth, if you look in older textbooks, particularly, and I have to say this, those written by TB specialists, the myth is there's very poor correlation between in vitro activity of drugs and in vivo activity of drugs against NTM. It's in a lot of textbooks. And, well, I'll give that away. It is a myth, and it's in fact not true, because there is very good correlation. But we have to realize a few things before understanding these correlations. So we'll start with the big deal, Mycobacterium avium complex. So as I said, the current regimen consists of Rifampicin-Ethambutol and azithromycin, a macrolide. In the previous days, when the macrolides were not yet considered for this disease, it was treated with combinations of rifampicin and ethambutol. Drugs which show very high MIC, so very little activity in the lab, and also very little variation in MIC. So there's no clearly highly susceptible or highly resistant strains. MICs are very stable and very, very high, up to 20 or 40 times higher than in Mycobacterium tuberculosis. And what we saw in the trial done by the British Thoracic Society was that regimens that were made up of rifampin and ethambutol yielded only a 27% cure rate. And now that sounds like it does a little bit, but if you look at series studying the natural history of this disease, you'll find very similar culture conversion rates, also in like the 25% range. So you might also say that maybe rifampicin and ethambutol together are as active as doing nothing. Now that's of course my opinion. But importantly, the trial noted that the susceptibilities to rifampicin and ethambutol were indeed very stable, and that the subtle differences did not translate into having a better cure rate if the susceptibility was sort of quite good. Now, the technique that was used in the trial is not to be recommended. It's not a validated method, and as I said, there was very little variation. But that's where this myth comes from, that there's no relation between in vitro susceptibility and in vivo outcome of treatment. But I would say it's the other way around. These drugs are inactive in the lab, and they showed inactive in a clinical trial. So I would say the correlation is perfect. The reason is these drugs are not in the regimen to kill Mycobacterium avium complex bacteria. In fact, we've learned, and first from a group in Tyler, Texas, led by David Griffith, that these drugs are primarily in the regimen now to prevent macrolide resistance from emerging. And that is obvious from case series, that macrolide resistance emerges readily if you use macrolide monotherapy for this disease, or if you use macrolide and quinolone combinations to treat. But if you use the otherwise inactive or hardly active rifampicin and ethambutol with the macrolide, then macrolide resistance becomes a very rare event, and treatment outcomes are way better than for the other regimens. Not good, but way better. So testing susceptibility to rifampin and ethambutol makes very little sense. MICs do not vary, and they are not related to clinical outcome because they are not in the regimen to kill the bacteria. And I'm going to switch to a side story here, because I can tell you honestly that I get consulted once every 2 weeks, I think, from someone who receives a lab report from a reference laboratory in a European country where it says, okay, the strain you have submitted or the strain of your patient is Mycobacterium avium, and it is rifampicin resistant. and ethambutol resistant. What then might happen, and in fact often happens, is that these drugs are stopped and the patient continues on macrolide monotherapy. So testing them, rifampicin and ethambutol, should not be done. But if you can't somehow avoid it, then reporting on them and using breakpoints, for example, from the TB field, is simply wrong and potentially hazardous to patients because they might get very odd treatment regimens with unclear efficiency as a result. Okay, so that was all my rage and banter about rifampin and ethambutol. So in essence, don't test anti-TB drugs like the classic anti-TB drugs. It will not get you anywhere in MAC. The macrolide is what one of my PhD students always calls the warhead of NTM therapy. So the macrolides do the job. They kill the mycobacteria. And what we've learned from very early case series is that indeed the efficacy of macrolide-based treatment regimens is very much affected by macrolide susceptibility. So the case series from 1999 from Japan by Tanaka showed very nicely that if you give rifampin, ethambutol, and in their case clarithromycin, then in patients with clarithromycin susceptible isolates, culture conversion rates were high, up to 75%. Yet, some of the patients had at baseline clarithromycin resistant isolates. And in that small subgroup, culture conversion rates were, think of the old BTS trial, 25%, because essentially they had been treated with only rifampin and ethambutol. Now, very recently, amikacin was part of clinical trials, and it was the inhaled liposomal amikacin formulation. And there too, there was a clear distinction in treatment response between those with amikacin susceptible and the very few with amikacin resistant isolates. And that was either resistance occurring during treatment or resistance that had occurred between screening and going into the trial. So overall in the trial, the culture conversion rate was 29%. But if you look at the patients with amikacin resistant isolates, culture conversion rate was 0%. So there was no activity of the inhaled amikacin based regimen for those with amikacin resistant isolates. So testing for macrolide susceptibility and amikacin susceptibility does predict in part the potential outcome of treatment if treatment can be given and endured by the patient long term. So that makes sense to test for macrolide and amikacin susceptibility in Mycobacterium avium complex. And then we're switching gears to Mycobacterium cansaceae. And as I alluded to before, treatment is essentially TB treatment without pyrazinamide. And again, very similar to TB, rifampicin is the key drug in this regimen. And it's rifampicin resistance that matters. Now, it's a very, very, very rare event, but it might occur. So overall, treatment for Mycobacterium cansaceae is highly successful with very good outcomes in over 90% of the patients with the rifampin ethambutol isoniazid regimen. Yet, in some case series, patients have failed, sometimes due to non-compliance. And what was seen upon treatment failure is that the strains had acquired rifampicin resistance. What we've also learned recently, although its clinical impact is not yet that clear, is that exposure to macrolides, for example, prolonged macrolide maintenance therapy for bronchiectasis, might lead to mutational resistance and macrolide resistance phenotypically in mycobacteria, including Mycobacterium cansaceae. And probably the macrolide-based regimens are then completely ineffective. So in Mycobacterium cansaceae too, there is a clear role for drug susceptibility testing, particularly in case of treatment failure, but also I think at baseline to know what you're up with, and that is to test susceptibilities to rifampicin and macrolides, and in the lab that typically means clarithromycin. And then, I realize that this is like, whoa, a lot of data. The last one is the most difficult one, and that's Mycobacterium abscessus. Now, Mycobacterium abscessus, of course, is a completely different bug. It's a rapid grower. Some say it's actually closer to Nocardia than it is to the other mycobacteria. And its drug susceptibility, of course, also a completely different ball game. But what we've learned from in vitro, in vivo correlations is obvious. So the cure rates, as I said, are very, very low, up to 45 to 50% across cohorts. And that is similar in patients in whom treatment was completely guided by drug susceptibility at the start, and those who received sort of fixed regimens. The problem is, if you look at those cohorts, patients do not stay on their medications for long because of massive drug toxicity issues. So maybe they did have an active drug, but they couldn't tolerate it long enough for the drug to be truly active. So that really hampers a lot of in vitro, in vivo correlation work. What is clear is the role of macrolide susceptibility. Again, macrolides. So we've learned that a part of the Mycobacterium abscessus strains are susceptible to macrolides, whereas the majority of isolates in most settings show inducible macrolide resistance. And it is in those strains where that macrolide resistance system is broken, the isolate is susceptible. It's there in that subgroup where we see the treatment outcome with macrolide-based regimens is quite good, whereas it is very poor in patients infected with strains that have functional inducible macrolide resistance. So testing for that in the lab is crucial to guide patient care, regimen selection, but also as a prognostic marker. And that may sound odd, but it's actually something that we discuss a lot with patients. So we speak to our patients about inducible macrolide resistance because it matters so much to prognosis and to the likelihood of a good treatment outcome. So again, macrolides, very clear correlations. For amikacin, similarly, there is a trial that has shown a correlation, although that was a trial where both MAC and M. abscessus were included. The number of abscessus patients was small, but it was the first trial using liposomal amikacin inhalation. What was clear, even from that small subgroup that had abscesses, was that amikacin resistance led to complete failure of the liposomal amikacin therapy. So correlations between in vitro and in vivo, so treatment outcome, are good for macrolides and for amikacin, as in MAC. Probably these correlations are as good for other drugs, but they have either not been studied or the long-term drug use is just nearly impossible, which is true, for example, for tigecycline, where we think we see activity in vivo, we see clear activity in vitro, but it's very hard to correlate the two, also because very few people can tolerate the drug long-term. For other drugs, fluoroquinolones, linezolid, cotrimoxazole, MICs are generally very, very high. So by the existing CLSI criteria, we have to label them resistant. So we are very reluctant to use these drugs in treatment. So we think there's a correlation between those high MICs and those drugs not working, but it has not been specifically studied. And honestly, I would not sign up for a study like that because of the lack of in vitro activity. Okay, we'll breathe out, pause, and recap. I hope you realize that there's actually quite good in vitro, in vivo correlation. Drug susceptibility testing for NTM matters in treatment of patients, in designing optimal treatment regimen, and in establishing, in part, a prognosis. So for MAC, Mycobacterium avium complex, testing macrolide susceptibility matters. Testing amikacin susceptibility matters, particularly in patients who are candidates for either IV amikacin or liposomal amikacin inhalation therapies. For Mycobacterium kansasii, a bit more like TB, rifampin is the key drug. Susceptibility testing is useful, particularly in those who have already been exposed to rifampicin. And the same goes for macrolides. And then for abscesses, it's clear that the macrolides are very, very important. So testing for inducible macrolide resistance, or in fact, acquired mutational resistance, and testing amikacin susceptibility. Okay, so the last bullet on that list of basic criteria for DST is that the in vitro activities of drugs should vary. If they don't vary, you don't have to test because you already know the answer. And that is something that I think is not always appreciated in NTM, that a lot of susceptibilities are actually fixed. You know what the MIC for drug X will be. Generally, it will be very high. Why is that? Because I always say 90% of all drug susceptibility in NTM is cell wall impermeability. Most drugs will never, ever reach the inside of a mycobacterium. Now, Mycobacterium tuberculosis is, I think, a little bit the odd one out, hyper susceptible. But for the NTM, very few drugs actually pass their cell walls. If they do, there's of course efflux pumps, there's biotransformation with beta-lactamases, aminoglycoside converting enzymes, and converting enzymes for fluoroquinolones, for example. And then one level beyond, there's other adaptational mechanisms like the inducible macrolide resistance, and there are similar mechanisms to protect, like the RNA polymerase from rifampicin and a couple more. But it's a massive fortress with a huge wall that first has to be passed. So what you can say is that susceptibility testing in NTM is largely done by just identifying the isolate. Why? Well, if you know the species, you know 90% of the susceptibilities. Because if you're close to TB, Kansasii, Marinum, you're susceptible to virtually everything that you test. If you go away from that, you go into MAC, resistance, or at least very high MICs to classic anti-TB drugs, to fluoroquinolones, to gotramoxazole are rife. If you go into the Simier complex, it gets even worse. And if you cross the barrier to the rapid growers, again, you see huge differences based on a lot of things, but in part reflected in the phylogeny. So the smegmatis group, not very pathogenic, but also highly susceptible to drugs. Fortuitum becomes a little more resistant, but plenty of options. And the Cheloni abscessus group is just a nightmare, resistant to most classes of antibiotics. Again, based on formidable cell walls and all kinds of other defense mechanisms. So for a lot of drugs, susceptibility is just determined by natural occurrence, so the cell wall and all those natural mechanisms. MICs will always be the same and generally just be very, very high. And it makes very little sense to test for those drugs and very little sense to use them in therapy. Unless, like the Rifampicin-Ethambutol story, they somehow add something that is not killing capacity. So then the big question is which method should be used, and we've already tackled a large part which antibiotics, but the method also is subject of a lot of debate. So in the European Society for Mycobacteriology, it's always a little hard to say that somehow the Americans made a head start, perhaps not for all the right reasons, but CLSI simply put out a guideline saying, well, this is how you should do it. And they've done that quite a while ago, promoting the use of broth microdilution, which of course is also a standard method in general bacteriology, and hence I like it. I like it not just for the method and the fact that you really determine MICs, but also this method was used in the very few clinical trials and larger cohort studies in this field. So the in vitro in vivo correlation that we discussed is all just for this one method. Now, CLSI also publishes breakpoints for a lot of drugs. They are generally based on MIC distributions. Their clinical meaning, I think, remains to be established for many of these drugs, but at least this is what we have. Other methods like e-tests, are very poorly reproducible, also very hard to standardize, by the way. Proportion methods have the same issue and also have no established breakpoints. And everyone's favorite baby, the midget, could be a very useful method, particularly for slow growers. But there are a lot of adaptations that you have to do, to somehow temper the growth rate, and breakpoints have never been established. And settling to a fixed protocol for that is tough, but can be done. I'm convinced about that. So, as I said, breakpoints exist. CLSI has published breakpoints for a lot of drugs, and I've taken the example of amikacin. Well, the breakpoint really is based just on MIC distributions. By chance, it aligns pretty well with mutational resistance. So if you have the famous 16S mutation, the MIC is way above the breakpoint for resistance. It has not been based on formal studies of pharmacokinetics and pharmacodynamics. So if the isolate is susceptible and the patient has a peak serum concentration or an AUC within target ranges for amikacin, that does not mean that that will predict a good outcome of treatment. That has not been studied. And also the breakpoint has not been formally tested in clinical trials, although there is an analysis ongoing, and a part of it has been published or presented at the last ID week, the last physical ID week, suggesting that there was not a clear correlation between the exact MIC and the chance of responding well to inhaled liposomal amikacin. So again, suggesting that, well, the breakpoint maybe needs some additional study. So, well, we discussed which drugs to test. I deliberately, also because of the meter that you can see there was already a lot of information, so I did not touch upon moxifloxacin and linezolid. I firmly believe that both have no place in treatment of Mycobacterium avium complex disease. MICs are very high, and the breakpoints are very poorly defined, way above what we use as breakpoints for TB, for example. And that, I think, should always make you a little cautious. So what are the new developments in this area before we go into the treatment arena? Of course, next generation sequencing. I don't know if you've joined the first few lectures in these series, which were awesome. Of course, next generation sequencing, allows you to do drug susceptibility testing in Mycobacterium tuberculosis to quite a large extent. In NTM, that's still an evolving science. We know some resistance-conferring mutations. Finding them obviously tells you there's resistance, not finding them does not yet tell you that the bacterium is definitely susceptible. So that needs a lot of work, but that is a work in progress, and it's something that we are very active in my group. The really good news is UCAST. UCAST is good news in general, but particularly that they're starting to look into mycobacteriology. So there is a reference method being made. There's one for Mycobacterium tuberculosis. There's one in preparation for the NTM. So that will lead to things like ECOF determinations, and I think a much more scientific approach to setting breakpoints, etc. So that's, I think, a very positive development. And then, especially if you can couple that with PK/PD science, I'm a huge fan of the hollow fiber model to study, the interactions between exposures to drugs and response to those drugs. What do you need to kill these NTM? Also, I love them because they're animal-free. But that's another way to inform breakpoints and improve susceptibility testing. So there are a lot of good things happening, and I think susceptibility testing 3 years from now will look different for NTM than it does today, and hopefully that will lead to better treatment outcome for patients. And I'll skip this for time. It was just it was a side, a nice aside, a horrific aside as well. To step back into treatment. So we discussed at the start, there are new recommendations out. The classic 3-drug regimen for avium complex, Rifampicin-Ethambutol-Azithromycin, specifically azithromycin, plus for those who need it, amikacin, plus for those who fail on treatment, the addition of inhaled liposomal amikacin, after at least 6 months of treatment have failed. Of course, the classic regimen for Kansasii and abscesses we discussed. So let's dive into that a little deeper and look at, okay, so what impact does that make? So what we've seen in meta-analyses is that the classic 3-drug regimen for Mycobacterium avium complex pulmonary disease leads to prolonged culture conversion, so culture conversion and then culture negativity until the end of treatment in some 70% of patients. Macrolide resistance, again, a reason why macrolide susceptibility testing is important, is a key risk factor for treatment failure. And so is fibro-cavitary disease. And we think that is also because of the very high bacterial load, because in patients with fibro-cavitary disease, the outcome is poor, but in patients with the nodular bronchiectatic disease, outcome is poorer if the bacterial load at the start of treatment is very, very high, so if they are smear positive. Well, we discussed, of course, the macrolide monotherapy or macrolide quinolone combinations, which some people somehow still see as a potential treatment regimen, are an absolute no-go because of the emergence of macrolide resistance and then a virtually incurable disease. So the brand new thing is liposomal amikacin inhalation, which was trialed in patients who had failed on conventional treatments, who were then randomized 2-to-1 to either receive or not receive the inhaled liposomal amikacin. Culture conversion rates in the group that started on amikacin was 29% versus only 9% in those who didn't. And you have to realize some of these patients had been on treatment for years before going into this trial. So maybe future studies will show slightly better figures. But it is now in the guideline for patients who have failed on at least 6 months of guideline-based therapy to add this drug to their regimen. And well, as someone active in the TB field, of course, that hurts. Adding a single drug to a failing regimen simply hurts. So I don't think that's the way forward. I think additional companion drugs might be very important. Clofazimine is my personal favorite, but that's opinion only. And the other challenge, I think, is seeing whether this drug also has a role in first-line treatment. So Mycobacterium kansasii, I think we by and large discussed. The regimen that we've settled upon for the guidelines is INH Rifampicin-Ethambutol. You might exchange isoniazid for a macrolide. Very good overall treatment outcomes in either regimen. So, and then I'd like to take the last few minutes to dive again into the treatment of Mycobacterium abscessus. So this figure comes from the cystic fibrosis guidelines. So the guidelines on treatment of this bacterium in cystic fibrosis patients. And I use it because it's a very visual representation of what's happening. So the current guideline says start with at least 3 drugs with proven in vitro activity. Now, roughly that translates into imipenem, although its testing is difficult, amikacin, tigecycline, and or azithromycin. So there really isn't a lot more that you can do. And so you realize this is multiple IV drugs. This is incredibly toxic. And then we always add clofazimine from the start because of its PK. It needs a long time to get to a steady state. So we start that from day 0. So this is an incredibly complex regimen, very difficult to tolerate. And then after a few months, you stop it and you go into what we call a continuation phase, and that's with oral agents. And you see examples of that at the bottom. Clofazimine, well, it's active in vitro. We don't really know what that means, but the MIC is low. Minocycline, not active in vitro. Moxifloxacin, not active in vitro, not active in hollow fiber models, not active in anything, and nebulized straight amikacin. Nowadays, of course, you could think maybe the liposomal amikacin might have a place there, but that needs to be tested in trials, because amikacin is, if you look at the hollow fiber model data, is not a very active drug against Mycobacterium abscessus. The MICs already hint at it, but it's not a very active drug. So what it actually adds to treatment is very, very hard to say. And of course, it might add a lot of toxicity. But it is among the very few drugs that shows quite consistent in vitro activity. Not much, but some. So the initial phase of treatment is sort of clear, but what you then do, so the oral continuation phase, we have to be honest, we just don't know what really works. And it's a very, very complex treatment. I already said the treatment, cure rates are in like 45–50% range. Slightly better if there's macrolide susceptibility, but in general, really, really poor outcomes. So I think the most important part of the new treatment guideline is really that it says, don't try this at home. Consult experts in either your local area or somewhere else, and then discuss. So what can this patient handle? Where are we going to do this if we do it? And then how? Which drugs are active in the lab? Which ones are maybe feasible for this individual patient? That's a very, very individualized healthcare issue. And I think it should ideally be done in expert centers. So is it all bad news? Yes. No. No, it's not all bad news. There are new treatments on the horizon. Of course, the liposomal amikacin inhalation was very good news. There are other drugs currently being studied to maybe in time replace rifampicin and ethambutol in MAC treatment, because it's nice to protect against macrolide resistance, but I would rather do that with a drug that also works in itself. So people are looking into clofazimine or clofazimine bedaquiline combinations. Minocycline is back on the map. Tedizolid is being studied, and in fact has already been tried in the odd patient. For abscesses, beta-lactam combinations are currently under study. Inhaled clofazimine has been tried in animal models and is currently under investigation to see if it can go into clinical trials. Inhaled tigecycline was tried by my own group, also in a mouse model, and seemed active. And omadacycline, a very new tetracycline antibiotic, also has in vitro activity against Mycobacterium abscessus, and since it's both an oral and an IV drug, if it works, it might have a serious impact on treatment. So hopefully that will also go into clinical trials at some stage. So what have we learned? Well, treatment of NTM pulmonary disease is really different regimens for different bacteria with different susceptibilities, most of them natural susceptibilities. So treatment for MAC, classic 3-drug regimen, Rifampicin-Ethambutol-Azithromycin with amikacin in case of very severe disease. Susceptibility testing is important for macrolides and amikacin because that will help you guide therapy. Kansasii, INH rifampicin-ethambutol or rifampicin-ethambutol-azithromycin, and susceptibility to only rifampicin and the macrolide matters. Isoniazid, ethambutol, MICs don't matter. They don't predict the outcome of treatment. Rifampin and macrolide MICs do. For abscesses, as I've shown, the classic starting regimen is imipenem and amikacin, and hopefully, if you've tested susceptible, azithromycin. If not, another drug, likely tigecycline. So I think testing susceptibility to those 4 is key. I think clofazimine is a key 5th one. And we have to realize for tigecycline, there's no breakpoint yet. So you'll find a very low MIC. Truth be told, we don't know what that exactly means. But so hopefully that has covered treatment, its outcomes, but also the role of drug susceptibility testing and how to do it for NTM. I realized it was a rough ride, a lot of information, but it was also a lot of topics. If you want to go over some of this in your own spare time, if you have any, there is a slide repository available from the NTM-net and the EMBARC websites that also cover these topics on NTM. And I'd like to end with showing you my great colleagues, because I'm here, but I'm only, as I said, one member of a very large multidisciplinary team with a lot of great people. And with that, I would like to say thanks. I look forward to hearing all your questions.
Thank you very much, Jakko, for this very comprehensive and interesting presentation. This is not easygoing or easy stuff, but on the other hand, we know it's extremely important and will be perhaps even increasingly important in the future with the more use of biological treatment, people getting elderly, etc. Perhaps I should say I'm Troels Lillebaek from the International Reference Laboratory of Microbacteriology in Copenhagen, where I'm the director, and I'm also a professor at the University of Copenhagen Global Health section. I've got that in the introduction. We're getting some interesting question. I think if you have Mycobacterium tuberculosis, you know that you can do genotypic susceptibility testing, and you have a very high accuracy for especially rifampicin and isoniazid. And Marco Derricks asked, how about the genes and in vitro resistance for non-tuberculous mycobacteria? Are mutation resistance related genes similar? For instance, we have the NTM-DR and so on, but can you say a little bit how reliable are genotypic susceptibility testing when it comes to non-tuberculous mycobacteria is the question.
Yeah, that's a great question. And of course, the honest answer is we don't know yet. What we do know, and that's also why I think the NTM-DR line probe exists, is that some mutations that we know including some that we know from TB, in fact, are also relevant to the most common NTM. So for avium complex and abscesses, we know that the one particular mutation in 16S leads to amikacin resistance by definition. You find a mutation, there is full resistance. Same is true for macrolides. We know that in the 23S gene, there's a small spot where two mutations are common and both are clearly associated with resistance. And of course, you can, by molecular means, also look at the gene for abscesses. And if you sequence that, you can see whether there's major deletions or mutations, and that helps you to determine whether there's inducible macrolide resistance or not. The big problem is still that we can tackle some using these mutations, but these mutations are not the full story. If you find mutations, there's resistance. If you don't find them, susceptibility cannot be guaranteed. Now, of course, that's also true for line probe assays for Mycobacterium tuberculosis, but there, I think, sensitivities and specificities reach well over 90%. If you look at studies, at least the one study, for example, that Timothy Walker and his group has done on abscesses, looking for macrolide susceptibility, sensitivity was roughly 60%. So there's a lot to be learned still about secondary mechanisms for a lot of anti-NTM drugs. So it's being studied. Some mutations are clearly linked to resistance. That's what the NTM-DR line probe will tell you. If you don't find a mutation, susceptibility is not near guaranteed.
Yeah, so we are moving in that direction, but it's not anything as close as for Mycobacterium tuberculosis. There's another interesting question from Francisco Liva. She asked, does drug monitoring have any role in NTM treatment? And if yes, do you have any examples, measuring the antibiotic concentration in the blood of the patient? Does that have any role in NTM treatment? Do you use that in your setting, or?
Yes, we do. And I do think there's a role. Of course, the role for therapeutic drug monitoring is always twofold. So one is to make sure that you reach exposures that you need to generate an effect. So for the bacterium to be effective. The other, of course, is to monitor for the risk of toxicity. Now, in patients who start on amikacin-based treatment regimens, of course, the need for therapeutic drug monitoring is obvious, and I don't think anyone will deny that. For the other drugs, it is not that clear in NTM disease what the role of drug susceptibility testing and then relating that to therapeutic drug monitoring really means. But there are clear drug-drug interactions, like between rifampicin and macrolides. So we do use therapeutic drug monitoring in some patients. We are not that interested in rifampicin and ethambutol levels, for example. Macrolide levels we do look at. We also tend to use higher doses of azithromycin, so 500 milligrams a day, to cover for that interaction with the rifampicin. And if we see some types of toxicity that we think that might be the azithromycin, we do check drug levels, because for some toxicities, again, drug levels are relevant. So the higher the drug level, the larger the chance of that occurring. And of course, there are some others as well, some sporadic use of this. But I think that's primarily the things that we do. And out of curiosity, we also do pharmacokinetics of clofazimine, but that's because it's so poorly understood how this drug works over time. But amikacin, always macrolides up on indication, mostly for toxicity, not so much for efficacy.
It's a little bit the same in Denmark. We also, if we have people with renal failure or liver failure, if you have short intestinal patients and so on, then perhaps also there's a role for that. You touch, I think, especially treating Mycobacterium abscessus is really, really difficult, and perhaps even more difficult in cystic fibrosis patients compared to pulmonary patients without cystic fibrosis. I don't know if you have had the same experience in the Netherlands. And also, is there any role for some of the new drugs, especially bedaquiline and delamanide, perhaps there? Or I've read only casuistic things on the internet or at PubMed. I haven't really seen any good studies on that, but perhaps you know of some.
Yeah, so there's two issues really. So one is, do we also recognize that treatment outcome of Mycobacterium abscessus disease is particularly poor in cystic fibrosis patients? Yes, we do. Of course, we also see more issues with drug resistance because of extensive tobramycin exposure, because of macrolide monotherapy for the bronchiectasis component of cystic fibrosis. So we see more issues with drug resistance. Of course, there's also the brilliant Josephine Bryant paper in Science showing that perhaps the strains that affect cystic fibrosis patients are different and are tougher to treat. But that's certainly something that we recognize from clinical practice. The efficacy of new anti-TB drugs is a tough subject. So bedaquiline has been tried. And it seems to have some activity against Mycobacterium avium complex in vitro. It's not the activity that we know from TB. It's a lot less. Well, I would say it's at least 10 times less active. The few cases published have shown a temporary effect. So you start the drug, you add it to the existing regimen, and you see a temporary effect. You might even see culture conversion, or you see bacterial loads go down, but then come up again. And what we and also the colleagues in Texas have shown is that re-emergence is the result of mutational resistance, with mutations in an efflux pump regulator system, which is also relevant to Mycobacterium tuberculosis. So bedaquiline, I don't know. I don't think it will ever be an active drug against NTM. Of course, when you're totally desperate treating Mycobacterium abscessus, there's very little else. You might give it a shot, but don't see it as an active drug. Don't expect miracles, because it's not that miracle drug for NTM, although I do think it is a miracle drug for MDR-TB. So delamanid's a very different story. It has hardly any in vitro activity against NTM. It's only against a few odd species, and it's never been tried. We have also never tried it ourselves, also because we cannot yet determine in vitro susceptibilities to it for NTM. For TB we do, but not for NTM. Once we get that going, we might get a more clear idea of which species might be amenable to delamanid treatment.
Another good question. It's from Arash from San Rafael Institute, Milano. He says, thank you for a great talk. I can say that as well. But then he also asks, what about the susceptibility patterns of Mycobacterium chimera? Are they comparable to closely related species? We had this problem with chimera in heater cooler units, and actually a serious situation for some persons who underwent open heart surgery. But do you know anything about drug susceptibility and Mycobacterium chimera? Can we look for close related strains, or what do we do in that case?
So Mycobacterium chimera, if you look at its natural susceptibilities, is very clearly a member of the avium complex. Its susceptibility pattern is very close to that of Mycobacterium avium. So drugs like Rifampicin-Ethambutol have hardly any in vitro activity against this bacterium. But it is usually, if there's no pre-treatment, it's susceptible to macrolides and to amikacin. So in terms of its drug resistance, it's not that different from any other Mycobacterium avium complex member. Certainly not very different from Mycobacterium avium and intracellulare. if anything, some of its MICs might be a step lower, but then you're going from really, really high to one step below really, really high. But yeah, that's so typical avium complex.
Okay, thank you. I think we're getting close to the end, unless there's some burning question. I can see, Daniela, that you joined the line. Daniela, do you have any additional questions for Jakko or any comments?
No. It was a great seminar, and congratulations. I think it was very useful for all the participants. And then Troels, if you would like to close the session and tell the participants that they can get the certificate for attendance contacting AL.
Super. So remember to get the certificate for attendance if you need that one, and thank you for participating in the seminar. Also note that these seminars are actually available afterward on the European Society of Mycobacteriology homepage. So feel free also to go to the homepage and have a look at the other talks, the one about Mycobacterium tuberculosis susceptibility testing, and I think there will be an additional one more. So feel free to go to the European Society of Microbiology homepage. And first of all, thank you, Jakko, for taking time today and for giving a very interesting presentation. It's really a difficult subject. I'm sure we will do this again in the future. But on the other hand, it's really a fast-moving area. So, well, I think even for the slow-growing non-tuberculous mycobacteria, we will know more in the future, and things are really going to change, in my opinion, for the next perhaps 5 years. I'll leave you for the last comments.
No, thank you very much. I greatly enjoyed it. Thanks again to the European Society for Mycobacteriology and BD for making this happen. And I greatly enjoyed doing this. So I talked way too much. I realize that. I'm somehow sorry for that. But feel free to connect with me by whatever means if you have additional questions or if you want to start a debate, which I love.
Thank you to everyone for attending.